There we go.
There are 3 to 4 empty seats up here for people that are against the wall, if you'd like.
Yeah.
To go for. Yeah, so there's a 3 here and there's one over there beside us.
Oh, I just clicked the forward button. Thank you. So we have the belief, I think, that advance directives will facilitate adherence to the residents' wishes. Certainly a laudable goal. We hope to avoid treatment-related suffering. We want to facilitate appropriate use of resources, and this all gets packaged sometimes in the language of avoiding unnecessary hospitalizations. I find that a really interesting one because it begs the question, who gets to decide what's necessary or not? And I think in the context of uncertain prognosis within the long-term care population, that's a really, really important question. And I think some of that will come out in the coming slides. So to move on, did I move on? Yes, I did. Okay, I can't see what's going on back there. So the data that I'll be drawing on for the rest of the presentation came from my doctoral dissertation research, which was really looking at awareness of impending death in the context of long-term care. And so this slide shows you what I did in that research and what the methods I used. One was a review of the charts of 182 individuals who had died when they were residents of long-term care in a 12-month period preceding my arrival in those 3 sites. The second part, I used an ethnographic approach, thinking in terms of long-term care as a culture, and I used interviews and document reviews and observation and methods typically thought of in terms of ethnographic research. This was done in the context of the University of Alberta, so my ethics approval was from there. The data that I'm speaking to today, I collected thinking it might show me something about awareness of impending death. And I suppose in the end it did. I have a presentation this afternoon where I'll talk some more about that. But some of the data I collected were things like, it has a power of attorney for healthcare been identified? Is there an advance directive on the chart? What level of care? I thought that might shed some light on awareness of impending death. And I subdivided that data by age category, the younger folks being younger than 85 years of age, and the group I called the oldest old, or living in advanced old age, were 85 years of age or older. The 3 facilities where I collected data all used the same advance directive form, one that I think many people are familiar with, and I suspect the one that was referred to in the earlier stage, with level 1 being often called the palliative directive, and level 4 being everything you can do to keep me going. So this table, which I'm sure you can't see from the back, represents my findings in terms of percentages. So the nutshell version of this is that there was a very high rate of completion of the naming of a power of attorney, over 96%. There was also a high rate of completion of an advance directive form, again at around 97% of the 182 individuals. The next piece in the table shows the percentages by age group and by sex of who chose what level of advance directive. Now, the interesting thing from my point of view is that this data was gathered from the last quarterly review prior to death for the individuals, and that was between 1 week and 3 months prior to the death, but it was the last officially recorded data. And there were only less than 15% who had chosen the level 1 or palliative level at that time. There was even a smaller number that had chosen level 4 who said, you know, all the bells and whistles, please do everything. And a big bunch of people who were in the middle somewhere, 2 or 3. And depending on which subdivision you look at, it was kind of half and half. So people who were saying, I don't want you to do nothing, And I don't want you to do everything. Do something in between, either in the facility or in hospital. And I think that reflected some of the uncertainty piece going on there. In the end, looking at what happened at the time of death, there were actually very few transfers to hospital, and most deaths occurred in the long-term care facility, despite the fact that the last recorded directive at quarterly review for many had indicated going to hospital. So what was really going on was that the instruction was being changed very close to the time of death, and the data on the advanced care directives that was going forward to the Ministry of Health and Long-Term Care from quarterly reviews wasn't really reflecting what was actually happening on the ground. I think I just said what this slide is saying. I get talking and forget to click. So despite this business of very few transfers to hospital and death occurring in the long-term care facility, where it seemed people thought death ought to happen, there was a lot of angst amongst the staff in particular about what was going on in this dynamic process. Staff worried that they might have to provide care, essentially transfers to hospital, that they thought would not be in the best interest of the individual, and so they felt a real almost desperation to get this level 1 directive in place before death would occur. And so from the ethnographic portion of my study, I've pulled out some of the quotations that represent some of the feelings that individuals expressed. And I'm not sure if you can see that back there, can you? I don't know if it's helpful if I quickly read it out or not. Well, we have to have the directive right from the first, because the staff has to know what they're supposed to do, you know. You can't be trying to figure out whether they're a transfer or a DNR when they're crashing in front of you. You have to have it on the chart, because who knows if you're going to be able to find anyone to ask if it isn't there. I find this one quite interesting, because when I looked at cause of death data, it seemed to me it was unlikely that very many people were crashing in front of staff. The causes of death were much more creepy. Death crept up on people. It didn't suddenly happen. And so, and I don't mean that lightly, because I think this really is a significant problem for people who work in long-term care. And we bring with us a mentality of, you know, code or no code, crash or no crash, and that sort of thing. But it sort of provides a sense of what people think about, what they worry about, what's framing their approach to this kind of thing. Some of the other comments were also very revealing. Long-term care is for living. It just happens that 95% of our residents die here. What a coincidence. But we really have a very strong discourse about long-term care needing to support the best of living, and so that might hold us back from considering what would facilitate the best at the end of life as well. I'm not sure, but I think that was really important. You don't want to be the one who gives up, so perhaps moving to a level 1 was considered in some respects giving up, the care in place versus not kind of thing. We just had a woman who I would say is 100% palliative. Her PPS was 20%, and we had the conversation, but the family changed the advance directive from a 4 to a 3. It's just because the family's in denial, and that was another strong theme I heard, that families were in denial. They didn't want to talk about this, just go away. But a family member represented a whole nother perspective, which was, I ask a lot of questions. If you don't ask questions, they'll think you don't want to hear it. So where is that dynamic process between respecting people's readiness to go there, or their need to ask questions but not being invited to do that? Another RN who said, I'm not sure the PPS is helpful here. Many of our people have had a really low score for maybe even years, so the palliative performance scale in the context of oncology and a number of other illnesses can help us do some prognostication, but in the context of long-term care, there's really some important questions about whether that tool is useful or not. The staff on the floor has to recognize when the time is right. We wait until their true end of life within hours, and if we're lucky, we get days. So that really has the potential to reduce palliative care to end-stage pain and symptom management instead of that other thing that we believe palliative care can bring to a context and to people. The staff is just going around doing their jobs and like, oh, whoa, when did that happen? And then it's a scramble to get the family on board. So again, this sense of urgency that I think speaks to the need that people probably that you worked with felt about having that directive signed. You know, that's my touchstone in case things get crazy here. We like them to be able to die here at the home instead of in some hall where nobody knows them. So the fear of dying in hospital and away from what the staff perceived had become home. Oops, I moved it too soon. I can't go back. So I guess the hospital is supposed to be where the best care is, but I kind of think I would rather have Mom here where all the girls are almost like family to her. So again, that uncertainty about where is the best place to be. And I think from the family member's point of view, that comes into how can I show my love for my family member? How can I do the best for Mom? And this one really touched me. And perhaps some of you've read it already. Well, I don't mean to be crude or anything, but I guess it's kind of like what you go through with a pet. You have to decide if your cat, who's been one of the family, gets another chance, or is this it? Only I think it must be harder if you're mother. You're talking about, it's her life you're looking at. Like, wow, that's a big one to say. Guess what? No more antibiotics for you. And this one really touched me because I think it showed the deep concern, the deep love, and the impact of uncertainty about what's caring in a decision that many of us might look at as being a simple, it's futile treatment, what's the point, don't do it kind of thing. And this was from a PSW who felt that many of these residents had in fact become like family members to her. And this is a very meaningful one for me. I think what I took away from this was that the transition to the palliative directive occurred, usually, eventually, but oftentimes very close to the time of death, within a day or two at the most. That was by far when we got that transition. It usually happened when the staff noted a dramatic change in the resident's condition, called a physician, and the note on the chart always said that the individual had been deemed palliative. A call was made to the family to get the directive changed to a level 1, and morphine and Robenal were ordered and administered routinely from that point on. From the point of view of the meaning of this, it seemed like the mere presence of an advance directive wasn't sufficient to meet the needs of the staff. So if it was a 2 or a 3 or a 4, but death was looming, it didn't matter what the directive said. It wasn't meeting their needs for what they felt would be the best at the end of life for the individual. They were concerned that they might have to provide this, what they deemed to be inappropriate treatment, and so they felt pressured to get that directive at that late date. And it wasn't just for their own needs they felt this pressure, it was because of what they believed would be the best way for the individual's life to come to a close. On the other hand, there was a real concern that we shouldn't have this level 1 directive in place too soon. It shouldn't be started too soon. It needed to be at the end because things changed then. The care that was delivered was really different after the level 1 directive came into place. They didn't want to be perceived as giving up on the individual. So there was the perception and the belief of staff members as they communicated with family members that the staff's perception really became very powerful and influential in helping families to move along on this transition between levels of care in the directive. And the staff members worried that family members actually became obstacles to acting in the best interest of the resident. If the family was hesitant or reluctant to make the change, then it was perceived as being stubborn or being in denial or not acting in the best interest of the individual. However, the interview data from family members presented a somewhat different picture. And of course, that might be because of which family members I got to interview. But for what it's worth, the family members seemed to take their responsibility as advocates very, very seriously. They were not in denial, and they were not merely trying to meet their own needs. Not that the needs of family members of long-term care residents aren't important to try and meet. Family decision makers were motivated by the desire to do what was best, and this shows up in literature from many research studies. They want to do what's best, but they're not sure what would be the best in the situation they find themselves in. And the conflict between the values of protecting life and avoiding suffering was a very, very difficult place to be. And I think that was what we saw in the quotation that involved I'm thinking about this like how hard it is with a pet. It's this uncertainty that's so difficult. Family members were concerned about doing what was best, but uncertain what that was. What is the most caring thing to do in this situation? And so maintaining an advance directive at a level 2 or a 3, I think, was a way of saying, I can't decide yet. I don't know what it's going to be like then. This is the best I can do with the data I have available right now. And so this wasn't disinterest, it wasn't abdicating responsibility, it wasn't denial, it wasn't an unrealistic expectation. It was, this is what all I can do with in the situation I'm in right now. And from that point of view, we wouldn't be surprised then that the palliative directive was only put in place so close to the time of death, when it was undoubtedly clear that death was going to happen very soon. And so there wasn't a risk then that I'm denying something that would have contributed to fullness of life. Got to keep myself in the sink here. Thank you. So it may be easier to understand and accept that family advocates delay the transition to a level 1 until it's unquestionably clear that prolonging life is no longer the loving and caring thing to do. And that makes care planning and clinical decision making complicated, because you have to figure out what's the best balance here. How do I avoid interventions that are going to be troublesome or increase suffering with that not denying opportunities for the fullness of life? How do I know if this is going to change things or not? So decisions may be hampered by dichotomous thinking, having to decide, is this individual living or are they dying? As opposed to thinking about both of these things happen in an intertwined kind of fashion. I live until I'm dead, and I'm dying all the time I'm alive. And we have a strong and pervasive allegiance to life in our culture, and we value life equally for everyone without regard to age. And this brings us to the concern that permeates our society about ageism, something we don't want to be caught up in. But how do we find our way through that complicated web? So, advanced care planning is a difficult challenge. The timing of the transition in directives is particularly challenging in light of the uncertainty that characterizes the end-of-life decline for many residents of long-term care facilities. And the whole matter of familial love and loyalty enter into all of that. So I think what we found is that both staff and family members were uncertain, resolved their uncertainty by considering that no one was in need of palliative directive until death was unquestionably and unavoidably certain within a very short time. So this business of advance directives became a matter of only doing it when I'm certain that this is what's going to happen. So in terms of implications, there we go, implications. If we're going to call a level 1 directive the palliative directive, we have to really understand what we mean by palliative care, and perhaps that terminology leaves people needing a certainty that's impossible to have, and we shouldn't be surprised if that makes that decision very difficult. So we need to talk about it in terms of its the directive it gives to caring rather than simply to letting go or people who may perceive it as giving up. Staff members really need to be helped to become comfortable with conversations in family in the context of uncertainty. Thank you.